Assalamu alaikum. In this presentation, we shall go through the general lines of management for oral ulcers with specific examples, including the dosage of some of the common ulcers. Safety comes first, and one must maintain a high index of suspicion for sinister pathologies presenting with ulceration in the oral cavity, including malignancy. Certain features have to be watched for, including a non-healing, painless ulcer that had presented for more than 2 weeks, and any induration and lack of inflammatory signs of the ulcer, any ulcer with a rolled and thickened edge, and any special habits like smoking or alcohol abuse. Age is also a factor because 85% of the cases of oral carcinoma present at the age of about 50 years, mostly in men, and one should be aware of a previously diagnosed pre-malignant lesion in the area or history, including things like if there has been no history of previous ulceration and no local factors like a rag tooth, for example, that could potentially cause ulceration, and no systemic factors that could potentially cause ulcers. Some of the oral ulcers, particularly acute ulcers, can be painful and can induce a restriction in the oral intake with potential dehydration and malnutrition. Symptoms relief is important, including things like saline mouthwash, topical analgesics or anti-inflammatories such as benzidamine mouthwash or spray, and antimicrobial agents such as chlorhexidine mouthwash, spray or gel. Sometimes a barrier paste over the ulcer such as caramellose gelatin would also help in relieving the pain. Topical anesthetics can be useful, such as lidocaine spray or ointment, and sometimes systemic analgesics or even antibiotics or steroids can be used. It's useful to reduce or stop smoking and alcohol consumption, together with any spicy or acidic food or drinks, and also conditions that may predispose to oral ulcerations in general, such as iron deficiency anemia, avitaminosis, should be excluded. The general safety and important cautions advised by the American Academy of Family Physicians include things like topical corticosteroids are the mainstay for the inflammatory ulcers. Systemic steroids like prednisolone, for example, or colchicine, or immunosuppressants for severe or refractory disease should be under specialist care and control. The herpetic stomatitis, the treatment with antiviral should be initiated early, preferably within the first 72 hours from the prodroma. Suppressive therapy may be indicated if the disease is recurrent frequently. Topical steroids would risk, if prolonged in use, causing oral candidiasis, and the advice here is to use frequent mouth rinses or even antifungal suspension if suspected, and to limit the duration of the topical steroids to what is strictly necessary. Systemic immunosuppressants, including azathioprine, thalidomide, and methotrexate, would require specialist prescription as well and a baseline blood tests monitoring. Thalidomide, which is very effective for refractory recurrent Aphthous stomatitis or Behcet's disease, is highly teratogenic as known and can cause peripheral neuropathy and should be taken under strict control. The other important point is that one should always exclude a traumatic cause or a malignant cause for the ulceration if it persists more than 2 weeks, and despite removing the cause for the frequent trauma, or if the ulcer have any other suspicious features like indurated margins or bleeding or fixation, particularly in the elderly. The treatment for Aphthous ulcers is best initiated as early as possible. The ulcers may be covered with steroid pastes, things like 0.1% triamcinolone acetonide. It's best to dry up the mucosa around the ulcer before the application of the paste so as to allow it to adhere to the mucosa. Antimicrobial mouthwashes like chlorhexidine, povidone iodine, or benzetamine can also help in preventing secondary bacterial infection. Major aphthous ulcers seen in conditions like, for example, HIV disease may be treated by intralesional injection of triamcinolone, while the widespread resistant disease, corticosteroids systemically can be tried, perhaps coupled with steroid-sparing drugs like azathioprine. Other medications, including colchicine, dapsone, pentoxifylline, have also been used in the management with varying success rates. The first line for local treatment of aphthous stomatitis should always be a topical steroid paste or ointment, things like triamcinolone acetonide 0.1% in ora base, applied to the lesion somewhere between twice and 4 times daily until the pain improves, and it should be best applied after meals and avoid eating for about 30 minutes after the application. And topical analgesics or protective agents such as benzocaine gels or protective pastes such as sucralfate suspension rinse can also be helpful in reducing the pain. If this does not work, the second line to try would be high potency topical steroids like clobetasol 0.05% in ora base or fluconeuronide 0.05%. These may be used for larger or refractory lesions or recurrent lesions at the same site and applied again twice daily, between twice daily and 4 times. And using local steroids, one should monitor for oral candidiasis and advise frequent mouth washes. When to escalate and use systemic therapy? If the ulcers are very frequent or too numerous or very large, like major recurrent aphthous stomatitis, or impair the nutrition or the quality of the life, then short courses of systemic steroids that should be tapered at the end include things like prednisolone 0.5 to 1 milligram kilogram body weight daily for a short course, usually few days between 3 and 5, and immunomodulatory agents for very refractory disease such as colchicine or dapsone or azathioprine. These should be used under strict specialist supervision. Other options, now newly treated, other options include topical tetracycline or doxycycline mouthwash, and trials for rapid pain relief or healing for the ulcer included using photodynamic therapy and sometimes laser approaches. These are emerging, but the evidence is awaited and are not first-line management. Traumatic oral ulcer may enlarge or persist for several weeks if the traumatic insult continues, like a ragged tooth or an ill-fitting denture, for example, and they may get secondary infected. The management include coating the ulcer surface with a fluocinolone or triamcinolone acetonide in an emollient base after meals and before bedtime. This would relieve the pain and also decrease the duration of the healing. We move next to primary herpetic gingivostomatitis caused by herpes simplex. The condition is self-limiting, but the patient would usually require some supportive treatment in the form of rehydration, sometimes antipyretic or analgesics as well. Antimicrobial mouthwashes would be useful. Benzetamine mouthwash is particularly useful because it causes temporary numbing sensation in the oral cavity, which may make eating easier during the acute phase. In recurrent herpes labialis, things like hydroxyuridine in dimethyl sulfoxide, the Herpes solution, or acyclovir cream applied early to the lesion can be useful. Sometimes other systemic antiviral medications may be used, particularly in the early phases in the first 72 hours or so, including acyclovir 200 milligrams 5 times a day for 3 to 5 days, or valacyclovir 500 milligrams twice daily for again 5 days, or a single dose of famiciclovir of 3 tablets each 500 milligrams. These medications can sometimes be important in sinister conditions like herpetic encephalomyelitis. In cases of recurrent herpetic stomatitis that may be triggered by things like physical or emotional stress, ultraviolet rays, cold weather, hormonal changes in females particularly, or upper respiratory tract illness, or lip and mouth trauma. Symptoms can be relieved by things like sucking on ice or using lanolin, but applying acyclovir ointment 5% every 2 hours from the prodromal phase until the lesion subsides can be very useful. In severe cases, systemic acyclovir or other antiviral medications should be considered, best started early in the first 72 hours of the illness. And things like elective dental treatment should be postponed if the lesions are active to prevent aerosolization of the virus. To sum up the treatment options for herpes simplex virus, the treatment principles include using the antiviral medications early enough within the first 48 or 72 hours, sometimes as a first-line management. The options are acyclovir or valacyclovir or famciclovir with different dosages. If the disease is recurrent, then a short but high dose of oral regimes, including the valacyclovir 500 milligrams to 1 gram twice daily for 3 to 5 days, may be your better option. For severe primary disease or immunocompromised patients, intravenous acyclovir should be considered. Topical antiviral treatment in the form of creams like penciclovir cream have some benefit in the labial herpes simplex, but systemic therapy in general have superior results. Analgesia will be required, and topical anesthetic gels can also help in controlling the pain. If the condition is frequently recurring, then suppressive therapy can be considered, including low dosage of valacyclovir or acyclovir to prevent frequent recurrences. The condition is self-limiting, and the management consists of basically pain control, because it is particularly painful, and also some antiviral treatment, including acyclovir or other antiviral medications. They are more useful if started within 72 hours of the disease onset. High doses of systemic acyclovir can be required in cases of ophthalmic division involvement, and they can also be helpful in decreasing the incidence of post-herpetic neuralgia. The diagnosis of necrotizing ulcerative gingivitis is based on 3 factors: the pain in the gums, the bleeding from the gums, and the ulceration and necrosis of the interdental papillae. The treatment is based on removal, mechanical or chemical removal of the tartar, dental hygiene, use of chlorhexidine twice daily, and antibiotics in the form of amoxicillin and metronidazole 3 times a day for at least 7 days. Healing and improvement is expected within a week. Sometimes they can progress to the more advanced condition of necrotizing ulcerative periodontitis, which is severely painful. and cytomegalovirus-associated ulceration. Now, although more than 80% of adults would have antibodies against cytomegalovirus indicating previous infection, the presentation with an ulcer is not common. This usually happens in patients who are immunocompromised or stressed or weakened or have other diseases. This will cause a large ulcer, usually solitary, rarely multiple, and the ulcer can affect the keratinized or the non-keratinized mucosa, usually in the palate, but also sometimes in the lips. Can be sometimes painful, although in healthy subjects it would be asymptomatic and very shallow. It can persist for several weeks or even months. The treatment is a systemic antiviral treatment by valganciclovir or ganciclovir or cidofovir, and topical anesthesia if the ulcer is painful, and systemic analgesics if that is required. Eosinophilic ulcers are usually initiated by oral trauma, such as, for example, dental injections, and this would cause a granuloma that may ulcerate, and the stroma of the granuloma contains heavy eosinophils population. In about 2/3 of the cases, the lesion may be asymptomatic, but it persists for a good few months. The edge of the ulcer is rolled and a bit indurated, and if it is painful and had persisted for a long time, the diagnosis of a malignancy should be excluded. That's why the preferred line of treatment is surgical excision if the ulcer is not responding quickly to local medications. The surgery would be useful in controlling the ulcer, ruling out the possibility of a malignancy, and the recurrence of the lesion is usually rare. But before excision, one may try intralesion steroid injections or oral steroids, topical steroids, perhaps with topical antibiotics. Sometimes cryotherapy had also been used with good results. Several medications were tried in the treatment of Behcet's disease, including corticosteroids, azathioprine, thalidomide, and dapsone. Also, things like colchicine and cyclosporine had also been used. It was found that the anti-TNF-alpha infliximab has actually a good efficacy in controlling the recurrence and the resolution of the oral ulcers. Topical corticosteroids are not optimally effective against the oral lesions. The management of erythema multiforme depends on the severity of the condition. Avoidance of any known drug triggers is essential. In the mild forms of the disease, the healing would take place within 2 to 3 weeks, and the patients would need local wound care, liquid diet, and analgesics, and some pain control. But in more severe cases, systemic steroids would be required. In those cases who have a Stevens-Johnson disease or TEN, they require hospitalization as an emergency, antibiotics, and systemic steroids. When planus is considered a pre-malignant lesion, the risk of malignancy can be as high as 3.7% and can often develop even after 10 years or so. The most frequent sites affected is the buccal mucosa, followed by the tongue, sometimes the gingiva, the palate, and the vermilion border. Pathologically, the lesion would show hyperkeratosis, but also degeneration of the basal cell layer of the epithelium and the presence of subepithelial band of lymphocytes, the so-called interface mucositis. The demonstration of fibrinogen deposition beneath the basement membrane by direct immunofluorescence is diagnostic. For the asymptomatic subtypes of the lichen planus, no treatment is required, but just a good follow-up and perhaps also prolonged follow-up. But for those patients with symptoms like the erosive type, the treatment is usually topical or even systemic corticosteroids. Lichen planus is the most common skin condition to have oral manifestations and presents in several subtypes. The erosive and the ulcerative types are the one that requires particular attention. The first line of management for the erosive and the ulcerative types is high potency corticosteroids, local high potency corticosteroids like clobetasol, propionate 0.05% in oral base or as a gel applied on the lesion either between twice and 4 times a day, perhaps combined with short courses of steroids as well. But the second line, if the condition is steroid refractory, would include things like tacrolimus 0.03 to 0.1%. This is a calcineurin inhibitor. The evidence supports that its use is beneficial in the cases that don't respond to topical steroids. Systemic therapy can be useful, but should be reserved for the severe or the widespread disease in the form of either systemic steroids or methotrexate or azathioprine, and this should be done under strict specialist care. The condition is pre-malignant and the patient may need to be on follow-up for the low but the known malignant transformation risk. We move next to the vesiculobullous skin diseases that can cause multiple chronic oral ulcers, including Pemphigus vulgaris, the mucous membrane pemphigoid, the bullous pemphigoid, and the linear IgA disease. Clinically, the patients with Pemphigus vulgaris would have these large, shallow ulcers and sometimes desquamative gingivitis. The differential diagnosis would include the other forms of erosive mucosal disease, such as mucous membrane pemphigoid, erosive lichen planus, and Erythema Multiforme. They can be distinguished by a biopsy to identify the level of separation of the epithelium. This is an acantholytic type of lesion, and also direct immunofluorescence to localize the autoantibodies attached to the tissues in the suprabasal areas of the stratum spinosum. It can usually be treated by systemic steroids, sometimes in high doses, with the addition of steroid-sparing agents like azathioprine. Other agents have been tried as well. A maintenance dose can be monitored by the level of the pemphigus antibody in the serum. The diagnosis would be established by a biopsy, which would show that the epithelial separation level would be at the basement membrane rather than intraepithelial like in Pemphigus vulgaris. There is also no acantholysis like in Pemphigus vulgaris. Direct immunofluorescence would show a linear distribution of the IgG and C3 localized at the basement membrane as well. Clinically, sometimes there may be blood blisters. This is sort of a characteristic feature that occurs because of bleeding into the intact bullae. The treatment is usually topical steroids, but systemic steroids may be required, particularly if there is ocular involvement. In some refractory cases, then medications like azathioprine may be added to the steroid as well. Another vesiculobullous disorder is the bullous pemphigoid, which affects patients above the age of 60 years. It's uncommon to have oral manifestation for the disorders, only in about 16% of the cases. It leaves multiple discrete vesicle formations, similar to Pemphigus vulgaris lesions, but less painful and also smaller in size. It can also cause desquamative gingivitis, and it does not affect the lips as much as their affection in, for example, Pemphigus vulgaris. It's self-limiting and also has early remissions. It is being reported in conjunction with other diseases like multiple sclerosis or malignancies, or with the use of certain medications, particularly diuretics. The treatment is topical steroids in the management of the localized oral lesions, but extensive lesions would require systemic steroids either alone or in combination with immunosuppressive drugs as well. Another autoimmune subepithelial mucocutaneous disease is the linear IgA dermatitis, which affects mainly females. It can affect both adults and children, with a peak incidence at the 6th or the 7th decade of life. It affects mostly the palate, hard and soft palate, tonsillar areas, and the buccal mucosa, and can also cause desquamative gingivitis. The lesions are very similar to mucous membrane pemphigoid, forming vesicles that rupture and leaves about painful ulcerations and erosions, plus the desquamative gingivitis. They are usually managed by topical steroids, but sometimes dapsone therapy for the more severe cases is recommended, or systemic corticosteroids in very resistant cases. And finally, a practical algorithm for oral ulcers treatment that is usually used for most of the most common form of the acute ulcers is first to try and remove any known cause for the ulcer, particularly if it is a traumatic, and to use topical steroid pastes like triamcinolone 0.1% or clobetazole 0.05% in Herpes. This may be used for a few days, somewhere between 3 and 5 days, only a small amount, twice to 4 times a day after meals and at bedtime, and use analgesic mouth rinses. If there is reason to suspect a herpetic lesion, then start the systemic antiviral treatment early, within the first 48 to 72 hours, by valacyclovir or acyclovir. But if the ulcer is refractory or frequent or severe, then you may escalate to short doses of systemic steroids or refer for immunomodulatory therapy with things like colchicine or azathioprine or dapsone or other biological agents for things like Behcet's disease, for example. By this, we come to the end of this presentation on the treatment of oral ulcers for ENT and dental students and trainees. Assalamu alaikum.